share the screen. Okay. Well, it's a distinct pleasure and honor to be invited. I'd like to thank Dr. Anuradha Mishra for inviting me and Dr. Rangwala for introducing me with those kind words. It's truly, every time I talk about Mumbai University, it brings back a lot of memories. And I'm not going to give you, there are many stories. A few stories I would like to say, bring it to you. Since by the way, this is the picture of hospital area where I work. And this is about 1,400 acres, 17 hospitals, independent hospitals are there, about 17,000 faculty members, employs about 110,000 employees, and sees about 7.2 million patients a year. And this is called Texas Medical Center. I think it's one of the largest medical center. And this is where the Texas Children's Hospital is sort of hidden behind this. That's where I was working. These 17 hospitals are independent hospitals. They have no relationship with each other in administration, but they collaborate on many different levels in basic clinical research. After leaving the Bombay University, I came several times. Each time I come, I see is so much development on the campus. When I was a student, this was the building that we were housed in. This is a chemistry building. Like Dr. Rangwala said, there were maybe a couple other buildings. You can't miss it. So, and the land around it is totally barren. There was nothing going on. And now you see there's, full of these structures, and you need a guide to tell you where to go. So, which is indeed, it's good to know that it is really developed so well. And I got some pictures, photographs that I wanted to share with you. I am from the old school. I graduated in 74, and most of the speakers I see, except for a few, they were all graduated from after 80s, I believe. And I'm from the old school. And these are some of the pictures that Dushyant Kothari, my friend, sent me. Here is Dushyant. Here, Dr. Rangwala and Arun. And I think this is one of the seminars held from Tata Institute, I believe. And this is a picture of Dr. Joshi, head of the department. And this is his baby, iron implanter. So I wanted to tell you about the faculty. When I was a student there, we were about, I believe, about 20, 25 students, which were based in UDP. Besides, there were about 40 or 45 students who would come to UDP for lectures. And then they would go back to do their experimental part in their respective colleges. In that sense, we were sort of privileged where we could do both theory and experiments in the same building. And as faculty, we had Dr. Rangwala, Dr. Arvind Kumar, Dr. Padhi, and Professor Joshi. There are two Joshis, actually. One is H.C. Joshi, and the other one is Dr. M.C. Joshi, who's the head of the department. And we were, in a way, fortunate that we were given permission to some of the experiments in Tata Institute and also in BARC. For example, we did some Mosbar spectroscopy studies in BARC, some Hall effect studies in Tata Institute. In that way, we were very fortunate. I would like to cite one incident, particularly with MCJ. We call him MCJ, MC Joshi. He has, a unique work ethic. He had a big bunch of keys in his hand, and he lived on campus. So every day he would visit every lab in the building and see everything is okay. In the second year, I was given a project, and the project was to build a rectifier for a high voltage transformer that he had just purchased for a Debye X-ray camera. And that job was given to me to build a high voltage rectifier that needs to be housed in an oil container because a tremendous heat was generated in this high voltage through the high voltage transformer. And we had a very good engineer, his name is, I think his name is Patwardhan, if you recall. And he was very methodical, very smart guy. So I would talk to him about the design. He would cut those plexiglasses precise to the dimension that we talked about. Then he will cut them into pieces and he said, I will place this here. Tomorrow I will come and glue them together. In those days, the glue we used called araldite. I don't know if you remember glue. And we had plenty of those glues there. And what happened was Dr. MCJ comes the night before and he sees these plexi plates lying there and he will just put araldite and, globs here and globs there, and he builds it and leaves it there. So next morning we come and see it's ready there, but it is very shoddy work. Never it worked, it did the job. So that's the kind of a guy he was. He would come and do these things. Sometimes it is to your advantage. Sometimes you find that you could have done better. But he was always, behind all these things to make sure everything is running fine. Under his leadership, we were able to get a lot of new equipments, like the first multi-channel analyzer that came in at that time, and a few other equipments in the dark room, interferometers, etc. After I graduated in '74, you probably know Dr. Anuradha Mishra told you about my journey, various schools I went to. I was fortunate enough to work in the physics department as a demonstrator. Right after I graduated, Dr. MCJ one day called me, why don't you work? So I worked for 2 years. And during that time, I found all my classmates are already left, gone abroad. And I was getting letters from them say, why don't you also come? I wasn't sure what I was going to do with my life. So I was uncertain. Then I met Dr. Rangwala. He was, a great encourager, I must say. One thing he said was, whatever you do, wherever you go, do your best. It was important for them as teachers because their reputation was also on the line. So he encouraged me, so after that I applied for PhD, in Kent State because I wanted to do study liquid crystals, and that was the center at the time famous for liquid crystal research. So I joined there. Subsequent to that, I went to New York. I was a faculty member there. At that time, Dr. MCJ visited New York, and somehow he got hold of me, and I invited him to our campus to give a lecture. And he was gracious enough to come, and we had a wonderful time in New York when he visited. After that, I went back to school, and this was a turning point in my life. I changed my field from physics to medical physics, and rest is history, as they say. Uh, you might wonder, what is this medical physics? Medical physics is a field. This is another photograph here. You see MCJ and Dushyant, Dr. Rangwala. I don't know these folks here. Medical physics, they are the bridge between physics and medicine, because these days the technology is getting more sophisticated, complicated, and clinicians don't have time to study those aspects, the technology behind it. They just want to run the machine and get the results. And physicists are the key players. They are the link between physics and medicine. Their job is to help physicians understand and how to diagnose based on the physics principles. And by and large, there are two broad groups these medical physicists work in. One is in the diagnostic part of medicine, that is to diagnose using CT, MR, ultrasound, you name it. The other group is in the therapy side. They are primarily in the radiation oncology. They would develop techniques to develop how to induce the radiation therapy for the patient. So they work in the therapy side. These are the two main groups where these medical physicists fit in. Now, if you want to look at the contribution of physics in medicine, it all begins with Röntgen back in 1895, who first discovered the X-rays and its utility. This is the very first image of, I believe, his wife's hand or his hand, and this is a ring on his finger. So this is the very first picture ever taken using an X-ray machine. Then after, we have radioactivity that was discovered by Curie and Becquerel, for which they got Nobel Prize. And that's when the term medical physics came into being, because they could see its application in medicine, And looking at the history in the developmental side, you will see between 1890 and 1950, we began with the X-ray imaging. Then we have ultrasound, which came in 1950s using the sound waves. Then we had nuclear medicine, radioisotope imaging around 1950s using gamma rays. This era is 1890 to 1950. Then 1970 to 1990, almost 20 years gap in between, from 1950 to 70, nothing much happened. In the 1971, we had X-ray computed tomography, which we now call computed tomography. It used to be called CAT scan, that is computed axial tomography. Now we are able to do planar imaging. That's why it's called now just a computed tomography, where you could look at the morphology, anatomy very well. Then came in 73 a PET imaging, positron emission tomography, where you could do the functional imaging of the brain, not just the morphology. Now you get the function of the brain. Then in 1980s, we have now what we now in the clinical use is the magnetic resonance imaging, which can do both morphology, anatomic, as well as functional imaging. Back in 1981, the Wall Street had a big advertisement saying that in the technology section, doctors excited about device that could replace CT scans. That was about MRI, which in 1981 came on the scene. People were very excited, although this is not 100% true. It cannot replace CT scan. It will complement CT scan, but it cannot replace it because there are clear advantages of CT where MR doesn't really work well. So if you look at the history of MR itself, it began in 1944 with Rabi first measuring the magnetic moment of nucleus, for which he got, these are the years they got Nobel Prize, and it all began in the mid-40s, 1952, the first NMR phenomenon was explained by Felix Bloch and Ed Purcell, got Nobel Prize. Then in those days, to acquire data, it took hours because the integrator, analog integrator was a boxcar integrator, they used to call, which took hours. Richard Ernst developed the Fourier transform method, which reduced that time from hours into seconds. So he got Nobel Prize in 91. Then Kurt Wuthrich, he was using that to look at the molecular structure. And this is when first it was applied. It has become a tool for chemists, more or less, to use NMR to study the molecular structure. So only in 1980s, late 70s, and they got Nobel Prize in 2003, is Paul Lauterbur and Peter Mansfield. They used NMR to develop what we today have called imaging, MRI. It used to be called nuclear magnetic resonance. Now we call magnetic resonance imaging. And they were the first one to develop a technique where you can image. So I want to give you sort of what I want to do is take you through a journey in MRI to give you all the applications that it can currently do and where we are now in terms of its use and where do we go from here. Is there anything left in MR? That's what I want to talk about. To begin with, let me give you very briefest possible explanation of MR for those who may not know. By the way, the MR, you will find it is you will appreciate it. It's a direct application of what you learn in physics, directly applicable to studying in the clinical domain to study the human body, which is a wonderful, wonderful application, which there is no other what you call physics in the physics that you see such a direct application. First of all, arguably, there are three strands to the story of MR. Very first is the discovery of basic understanding of nuclear spin, particularly that of proton. We talk about proton because Proton is the nucleus of a hydrogen. And in body, we have 70% water, which is H2O. So we have plenty of hydrogen to play with. So that is our candidate for MRI is hydrogen nucleus or proton. Then came the development and methods to exploit how to excite these nuclear spins. It was in the field of spectroscopy. Initially, it was developed for spectroscopy, later for MRI. Then came the development of these high field superconducting magnets. In those days, magnets were operating at an extremely low field, 0.15 Tesla, I would say. Now technology now allows us to develop superconducting magnets, which can maintain extremely high magnetic field. Now, little physics here. You can think of proton as a tiny magnetic dipole. It is somewhat similar to a precessing top in a gravitational field. If you precess a top, which is familiar with, in a gravitational field G, obviously it will feel a torque, and torque is based on its weight and the distance from the center. So this is called torque, mgd. It also has an angular momentum, L. See, this ratio of torque over angular momentum is what is known as a precession. It begins to precess around the gravitational field at this rate given by this expression, torque divided by angular momentum. Exactly the same way, if you look at the nuclear spins, when you place in a magnetic field as opposed to gravitational field, it experiences a torque as well. And that torque is given by magnetic moment cross product with the magnetic field. Now, the magnetic moment is simply gyromagnetic ratio times the spin angular momentum. So the torque divided by this angular momentum, which results in the precession, which is exactly given by this expression. And this was first defined by Larmor. So it bears his name, Larmor's equation. So precessional frequency of a proton spin in a magnetic field B0, which has a gyromagnetic ratio of which is for hydrogen, it is a 42.6 megahertz per Tesla. So this is the precessional frequency, and that precessional frequency linearly varies with field. So working with the higher magnetic field, obviously you have a higher precessional rates. You can convert that into linear frequency with this expression. So you can see at 1 Tesla, that means we are operating at 42 megahertz, 1.5 Tesla for hydrogen, it is 63 megahertz, or 2 Tesla, it is 84 megahertz. So beauty of MR is different nuclei have a signature value for gamma. They are unique and different for each of these nuclei. So if I want to study sodium, for example, all I have to substitute gamma for sodium, so then I can find out what is the corresponding frequency for sodium at different magnetic fields. And there are studies done using sodium as a nuclei or a helium as a nuclei. So we can study different nuclei as long as we know what frequency we are operating at and what magnetic field we are operating at. So for recipe for MRI, simply place a tissue or a patient in the magnet, because of the proton having 2 states, 2 spin states, plus half, minus half, one being parallel to the magnetic field, another state being anti-parallel to the magnetic field. There is a slightly excess population in the state which is parallel to the magnetic field. And it comes from the Boltzmann's statistical distribution. So you can define that ratio by this expression. And we call this P as a polarization. In other words, the net number of nuclear spins in a state parallel to the magnetic field is given by this. This P is also we call magnetization in the MRI language. We don't use P, we say magnetization, and we work on the magnetization, how it reflects based on external radio waves and how we measure it. So we place the object, so then we apply a radio waves or radio frequency precisely at the frequency determined by the Larmor frequency. Then we look at the response coming from the tissue that is being reflected back into antenna, which is being picked up and then converted into signal and image. So you have a patient lying in the magnet. As soon as outside the magnet, these tiny protons are randomly oriented. There is no net internal magnetic field because they cancel with each other. As soon as you apply a magnetic field that is patient brought inside the magnet, they begin to align because of the slight excess population in the state parallel to the magnetic field, and which then begins to precess around the magnetic field B0. So we apply then a radio frequency pulse. This magnetization, which was parallel with the B, is tilted depending on the what we call flip angle or Ernst angle. Depending on the strength of this radio frequency pulse, you can give a desired flip. Once it is flipped, this radio frequency pulse is removed, then they begin to relax back. Their natural tendency is to be parallel to the main magnetic field. They begin to relax and come back to main magnetic field. In doing so, they take two paths. It is governed by two times called relaxation times, T1 and T2. And they have a important relationship. They are based on the molecular motion. The water molecule, if it is moving around or rotating where it is or vibrating depending on the status. So you can define its relaxation time scale, which all can be derived using the Stokes equation for correlation time. And we find that correlation time, tau, is related to the relaxation time and the magnetic field. We can see here the relaxation time for a different free water, viscous liquid, and solid, how they vary at different field strengths. So what discriminates within a tissue protons state, how it is. For example, in a CSF, like a cerebrospinal fluid, it is in a liquid state. There the motion may be different than when it is in a gray matter or white matter, more like a solid area where the protons are more restricted in terms of its motion. So depending on where it is located, or how the structure is formed, we have discriminating values for this T1. And this is what we use to derive what we call contrast in your image. This is how we generate contrast within the tissue. Look at, for example, cerebral spinal fluid in the center here near ventricle is dark. In particular type of imaging sequence that you use, we can make it appear dark, or we can also make it appear bright by simply changing the technique that we use to look at that. So the beauty of MR is you have complete control how you manage the contrast that you would like to see. And the disease process is simply the deviation from the normal appearance. MR is an indirect method to identify pathology. If I am looking at the normal brain, I know how it looks, how it appears under certain experimental condition. Now, if it doesn't look like that, then I suspect there is some kind of a abnormality or some pathology making it appear like that. And to make an image, we use a specialized gradients, what we call gradient coils, because remember, all these protons precess around the roughly same frequency. In order to discriminate one coming from the left and that coming from the right, we simply alter their resonance frequencies by applying what we call gradient in the magnetic field. I will not go into the technical details, but suffice to say that this is what Lauterbur and Peter Mansfield did to acquire image like this, and they got the Nobel Prize for that. Typically, you have a magnet, a gradient coil, and this is the antenna or the receiver coil, where you can pick up or transmit the signal to the patient. This is a head coil, so you can transmit to the head and then receive the signal coming from the head. These days, commercial magnets, MRI scanners look like that. It can be an open magnet where the magnetic field is vertical, or it can be a closed magnet, closed bore like this, where the magnetic field is around the axis, and or it can be like this, open, where the field is left to right. Now, just to give an idea, we are operating, say 1 Tesla is about 10,000 Gauss, just so that you know the units. We are right now exposed to Earth's magnetic field wherever you are, roughly average of half a Gauss, depending on where you are in relation to the equator. You can be exposed average of 0.5 Gauss. That means a 1.5 Tesla scanner is about 30,000 times stronger compared to Earth's magnetic field. That's what most commercial MRI scanners are operating at. Today, we have 9.4 Tesla, which is being tested in the research setting in the Duke University, and I believe one in Yale. This is 188,000 times stronger than the Earth's magnetic field. That tells you how strong a magnetic field environment we are subjecting the patient to. These are typical images that you can get. The beauty of MR is without having to turn your detector or the transmitter, simply by acquiring image in any plane you want. Here is the image in the coronal, sagittal, and axial plane. And again, these are different contrasts that you can generate simply by changing the operating parameters. Here's another example looking at the chest. This is a liver, spleen, these are kidneys. Here's a picture of a knee. You can see the meniscus if there is any tear. You know, most people have meniscal tear. They can see it very nicely, or a tear in the shoulder, labrum, rotator cuff tears, you can see it. So these are the morphology or the anatomy that you can very well define using MR today. Then came on the scene the contrast agent. These contrast agents are paramagnetic in nature. You know, the paramagnetic substance increases the magnetic field. And the paramagnetic centers are called gadolinium. Free gadolinium are very toxic. So in order to remove the toxicity, it is chelated with the different molecules. It is sort of a forms a shell around that, so it protects, so it doesn't become toxic. So wherever gadolinium goes, because it is paramagnetic, locally then it disturbs the magnetic field. So when it disturbs the magnetic field, what happens? The relaxivity in the vicinity where the gadolinium is, relaxivity increases from its original relaxivity by this amount. Since the relaxivity is the reciprocal of the relaxation time, that means the relaxation time is considerably reduced. When relaxation time is reduced, signal appears very bright in a particular setup. Here is an example of a patient with a tumor. Without giving any contrast, you can see there is a silhouette, there is a border, a margin that you can see. Beyond that, you don't know much. Then we inject the gadolinium, and the gadolinium gets into this tumor because there is a breakage of a blood-brain barrier. There is the membrane, there is a barrier which sort of broken down. As a result, the gadolinium can seep into this tumor. Since it gets into the tumor, its relaxivity went up, so T1 went down, so it appears very bright. On the other hand, if it did not light up, then we know that blood-brain barrier is intact, did not allow any contrast to get in. That means it could be a cyst. A cyst is differentiated from a highly vascular tumor because the breakage of blood-brain barrier. Without the contrast, we couldn't tell whether it is a cyst or a tumor. So we had to use an external agent such as this gadolinium chelase. So, now we took advantage of that, injecting the contrast agent. These contrast agents are usually injected in a forearm, antecubital fossa at the forearm, and the contrast gets into the bloodstream. Since it gets into the bloodstream, obviously the signal in the blood also increases because the T1 of the blood, which was around 1200, reduces to 200 because it is in the bloodstream. Now, if you look at this image here, this is a soft tissue. Roughly about relaxation time is 750. Blood is about 1200 in its natural setting. So you cannot really discriminate between these two. If you take the difference between these two, this is the difference that is plotted. Not much, around 0. But when you inject a contrast, the contrast stayed in the blood, its relaxation time is reduced. Now you look at the difference between the soft tissue and the blood, because the contrast didn't go into the soft tissue, it only is in the blood. It will only go in the soft tissue if there is some kind of a pathology allows it to go. Otherwise, it still remains same. So now you look at the soft tissue and the blood signal difference. It's quite large. So one can take advantage of this simply by injecting the gadolinium. We can look at the blood vessels very well. But the trick is to know, since these imagings are done very fast, because the blood gets into your venous system, gets into the heart, then gets into the arterial system, then goes back into the venous system. So it circulates very fast. If you want to look at the arterial vascular structure, you have to be able to image relatively quicker before it gets into the venous phase. It is not much time difference from arterial to venous phase. So we must know different organs require different times from the point where you inject to reach the target. For example, it may take a certain time to reach kidney. It may take a certain time to reach, say, aorta or distal vessels or heart. So you have to know how long does it take to reach the target area. So we do what we call a test bolus, inject a very small amount and find out how long it takes. Same conditions. We mix the gadolinium with the remaining with just a saline. So the total amount is kept the same that you would later on inject with the full gadolinium. And we find out how long it took. And accordingly, we set our timing of your acquisition and the injection so that we capture arterial phase. If you wait, then you will get venous as well. Here is some examples of arterial phase where you can see duplicated renal arteries. These are renal vasculature. These are kidneys. This is another looking at the subclavian artery. These are the carotids that is going up. This is the ascending aorta. And if you wait long enough, then you get a venous vessels also lit up. So you get a, sometimes it is not useful. We want to see only arteries. If there is any occlusion in the artery, we don't want to be masked by this venous vessel. That's why we have to time it correctly. So if I want to look at the whole body angiography, then I have to repeat this every station that I look. For example, this is called a station. This is a station which looks at upper neck vessels and the heart. Now, if this is called the field of view, which is about 200 or 250 millimeter. Then I have to move down to next 250 millimeters down to look at the another area of the anatomy. That means I have to again repeat the whole thing what I did here to the next station. So that means I end up using multiple injections, multiple doses of gadolinium contrast, which is not very good for patient. It is a renal, it's toxic. It is toxic to kidneys. So we want to be able to do with a single dose the whole body angiography. And this is back in 1995, there wasn't any technique that was available where we could use a single dose and do the whole body. So we came up with a mechanical device where we would put a patient on top of it, and simply a man stands there and pulls the patient from one station to the next. For example, this is the first station. As soon as you finish, we know the blood will flow down. Systemic circulation goes down from heart all the way to the feet. So immediately then he moved the patient. So the next area of interest comes in the magnet. Then we image that. Then you go to the next station. This is how in a single injection, we could do multiple areas. This is the device that we built. Unfortunately, its lifespan was only maybe 3 years. Then after, the industry itself came up with integrated scanners where you can automatically move the patient in the magnet. You don't have to manually move. Before that, we didn't have that. And here is some examples. By the way, this is me volunteering. As you can see, it was placed on my chest, then on my thighs, then on my legs. I can see this area, the first area, this is the second, this is the third. Then you can stitch them together and give the picture of the whole body angiography. Why do we do that? There are times you see there are multiple occlusions in, say, for example, diabetic patients or breast cancer patients where it is metastasized. We need to be able to look at the entire body, and we can't afford to use multiple doses of injection. So other applications of MR is diffusion sensitive MR. Again, Robert Brown back in 1828 first observed that movement of pollens. You know, he thought it is molecules are colliding with each other. Then Einstein was the first one to recognize the connection between this so-called Brownian motion to diffusion process. And based on theory, he came up with this expression that mean displacement is related to the square root of the diffusion and the observation time. How long do you observe it? So that's, it's again based on this statistical analysis. He used the classical mechanics, could not do that. Einstein treated this as a collective motion, as a diffusion, and came up with this expression, which is quite relevant in terms of MR. If my observation time is T, that is my pulse sequence time, and if there is a diffusion, then I can measure how long did it travel. Now, what is its application in the clinical setting? Here is an example. Now, these are the cells, and cells function because there are nutrients that can get into the cell, energy supplied through sugar, and also water is exchanged between intracellular and extracellular area. Water has to constantly go back and forth. And there are what is known as the pumps called sodium-potassium pump. It channels the water in and out constantly. For a normal healthy cell, this pump works all the time. So water is always exchanged. Now, if there is an event, an ischemic event that takes place, for example, patient has a stroke, okay? Why does he get stroke? For some obvious reason, there is a lack of blood flow bringing the nutrient to the cell. When that happens, these sodium-potassium pump fails. It fails to work. And when it fails to work, this water inside the cell gets trapped. There is no way for it to get out because there is the channel which was there. It is all closed because of the failure of this pump. So the water is segregated or collected inside. So diffusion is favorable if the water can move, fairly well. If there are too many water molecules and it has no place for it to move, that means diffusion is rather weak. So simply by looking at the diffusion weighted image, we can say, for example, here is a patient with a stroke. Conventional imaging didn't tell much. There was some bright signal, but we don't know what it is. Now, when you did the diffusion weighted image, what happened? That area, those cells in those areas, water was trapped within the cell, could not move. The diffusion was very weak. When the diffusion is very weak, signal is very strong. That means these diffusion value, the D that we talked about, is very, very low. So we can also map the magnitude of diffusion and create a map like this. It's called ADC map. These, if I put a cursor here and know the number value for the pixel, that tells you the diffusion coefficient for that cell in that area. So this has a unique advantage to look at these patients who have stroke or in the acute phase of stroke. We can see signal changing like this. Now, other advantage of diffusion would be in the cancer therapy. If this cartoon will explain everything. Here you can see all the cells are aggregated. Let's say they are so congested. There's a diffusion is rather weak, and you measure the diffusion. Let us say this is the diffusion curve, like a Gaussian curve. Now, if the patient is given some kind of a drug, obviously the effect of drug is to kill the tumor cells. Some tumor cells die, make room for water to move around. They are dead. So there is a space. Now water can move little more freely. Obviously now the diffusion is little stronger than over here. So if I measure the diffusion, it should be shifted slightly to the right. Now, if the drug works perfectly well, all the cancer cells have died, become necrotic, then the water has a lot of free space to move around. That means diffusion must be even stronger. So that this should shift even further to the right. So how do we use that in the clinical setting? Here is a patient with the anaplastic oligo tumor over here. And this is the pre-treatment. You look at the diffusion, somewhat like this. Then 3 weeks after the treatment, it looks like it has shifted to the right. That means the drug seems to be working, killing the tumor cells, allowing the water to move around. 6 weeks later, if you repeat it and see where the diffusion is, if it goes further to the right, the treatment is working fine. On the other hand, look at this one here, less effective. Here is a pre-treatment, day 6 post-treatment, it shifted, looks like it is working, but 11 days later, it came back. That means tumor somehow came back, became aggressive. So your diffusion now has moved back. Here is another one, astrocytoma. This one did not even respond to drug at all. This is a pre-treatment. You have diffusion here. Post-treatment didn't change its position. 4 weeks after treatment, still the same. That means this chemotherapeutic agent is ineffective in terms of treatment. So this could be used as a prognostic indicator in these cancer patients. We can also look at the diffusion in another way. We know diffusion in a tissue is not isotropic. What do you mean by isotropic? Here's an example. If I take a Kleenex tissue, a drop of ink, it sort of spreads isotropically all over. You know, it goes in every direction, same amount. On the other hand, if you take a newspaper, which has a makeup of fibers in the newspaper, you drop that same drop of ink, it is most favored in one direction compared to the other. That means diffusion here is anisotropic. So you can define in space, three-dimensional space, it would be defined as a tensor because we have multiple directions. And diffusion in one direction can affect the diffusion in another direction. So we use the tensor to define the diffusion. Why? If you look at the human anatomy, here you see these are the nerve fibers and the water channels, water channels parallel to the fibers much more easily than across the fibers. So we can use that to our advantage and then find out that diffusion tensor, the longest direction, and define that by, say, a point or an arrow, you know, in a pixel by pixel, and you connect these arrows. So this is an indication, the path that is parallel to the fibers that are organized there. This is not the fiber itself, but it is parallel to the fiber. Now, here is an example. We use that to look at the brain, which is called diffusion tensor imaging. As you can see, we are looking at the fibers organization in the brain here. Is a corticospinal tract coming from the spine, and these are the splenium and genu, and here you can see further, these are cingulum, which grows, and the color coding is very important. The industry or the scientific community has stuck with the 3 different colors. The green to represent the fibers going from front to back, posterior to inferior. Red is from left to right. That means connectivity between 2 hemispheres of brain. Whereas the blue is the superior, inferior, going top to bottom around the spinal cord. Here is another example of those tracts. So here you can see the application of diffusion tensor imaging in looking at this. What is the application beyond that? Is that here is an example. Here is a patient with a tumor, large tumor on the frontal lobe. And we want to make sure that the fiber organization, how it is structured, how the tumor is affecting the organization of these fibers. Why do we need to know that? For a surgeon, he needs to know this organization so that he can make his approach, which affects least to the healthy areas. You know, he doesn't want to approach any which way he wants. He wants to make an approach so it is the least destructive to surrounding tissues. And this is one way to look at it. Say, these are fibers organized or shifted this way. So I don't want to make approach coming from here. It may affect these fibers. So he will make an approach from this side. So for surgeons, it guides them before surgery. The other advantage of MR is in functional imaging. Now, we have been so far very good in looking at the anatomy so well. What about the function? Can you make brain think and look at the corresponding changes in the brain? You know, here's a cartoon. What if I'm thinking of something? What if I'm looking at something? Or what if I'm tasting something? Obviously, brain has a different parts, you know, different sections, and they are responsible for different tasks in the brain. Every time any of those sections of the brain are activated, then the demand for blood in that area increases because of the neuronal activity, because metabolism for that particular neurons increases because it is doing the work now. So when the neuronal activity increased, cerebral metabolic rate of oxygen that goes in increases, and that is accomplished by increasing the blood flow to that area. Now, blood, when the blood is increased, that has a oxygen, you know, it brings a rich oxygen to that area, giving the energy to that neurons to function. When blood is diamagnetic, you know, because it has oxygen. So obviously, its magnetic field has an effect to reduce the overall magnetic field. The signal is different than when there is less blood flowing. Okay. So if you look at the brain, different cortex has a different function. For example, this area, posterior area, is primarily a visual area. Any visual, what you see through your eyes is governed by this section of the brain. This is called the Wernicke area or the speech area. This is where you comprehend a language. And there is another area called Broca's area, where speech, you know, writing, reading, or speaking, you know, language. Then there is a motor area. This is responsible for your movement of your arms or movement of your legs, you know. So different areas are responsible for different tasks. If I look at something, this area is primarily activated. If I move my toes or arms, hands, this area is activated. That means the demand for oxygen is higher in this area compared to rest of the brain. So here is telling us what all the functions, activities will activate these sections of the brain. Now, here is an example with MR. As you can see here, when you, for example, we put a patient in the magnet, we ask him to close his eyes and just move his toes. Then we can see this part of the brain is active. Or we can ask him to move his finger tapping his fingers in a rapid succession. So we can see this part of the brain is active. Or we can ask him to, we tell him some words, ask him to comprehend those words, understand those words, silently discriminate those words. Then we have this Wernicke area is activated. Or we show some pictures in front of his eyes in the magnet, then we can activate his visual cortex. As you can see, this cortex is highlighted. And what is the application? Again, oops. Again, in the before surgery, if there is a patient, if he has a tumor in the brain, we want to find out functionally what areas are working well around that tumor. If there is a tumor in this area, let us say, we want to make sure it is not overlaying or overlapping to the cortex, which is responsible for his movement of his arm. The surgeon wants to know how to make his approach to reach the tumor. He wants to make sure that he is not affecting the healthy area of the brain, minimize the destruction of the surrounding healthy tissue. That was the whole idea. So this has been a tremendous tool for pre-surgical evaluation of the patients. Now, I just want to say, this was my work done in Michigan when I was with Beaumont Hospital. In 2012, I moved to Baylor College of Medicine in Texas. I was asked to sort of work with the physicians there to develop fetal imaging program. Of course, now I'm switching from adult MR into fetal MR, which is rather challenging in itself, because here is a picture of a fetus. This is the abdomen of the mother, pelvis of the mother. This is her spine. These are her kidneys. And I'm going back and forth to, this is placenta, and this is the baby. As you can see, baby's brain. And the problem is the fetus constantly moves. What you were able to accomplish in adults, you couldn't simply translate into fetus. In adults, we were spending a lot of time in imaging because patient could hold very still. He wouldn't move. Here, we have no control over it. That's why we try to do late trimesters. We don't want to do early first trimester because the baby is literally swimming around, so it doesn't stay in one place. Second and third trimester is fairly well fixated in the pelvic area of the mother. So we try to do in the second or third trimester. We have better luck with that. And what we were able to do, we were able to do three-dimensional imaging, provide them a picture of how the baby is. This is an example of a twin. And we are also able to calculate or evaluate the brain anatomy in terms of its volume, various cortex volumes we can provide, because this is very important to see as the baby is growing or developing, is it falling in the right range of measurement. So these are three-dimensional imaging of the baby. Then we subject to standalone computer, and this can be done within an hour. Here's an example of utility of MR. Here is a baby which has what is called a neural tube defect, or the common name is Spina Bifida. You probably heard this common name, Spina Bifida. What happens in these babies when they grow up, they have some kind of a motor disability, their comprehension disability, a lot of problems. what happens is in these babies, the cerebrospinal fluid, which is shown in red, it leaks out of this tract. When it leaks out, the level of the spinal fluid is decreased. It is the spinal fluid which holds the brain in the cavity, as the baby is growing. When the pressure of this fluid is decreased because of the leakage, the brain begins to sag down and it actually gets out of the cavity as a result, simply because of the gravity. So when that happens, that syndrome is called Chiari malformation. Here is another baby with a large myelomeningocele. It's the same like this, but it's much larger. So what do we do in MR? Texas Children's Hospital is, they have a very high risk patients they see there because they do a lot of research over there. What we do is use MR to image this baby prior to surgery. Then they do perform the surgery. Then we do the MR again and look at the brain. If the brain now went back into the cavity, that means CSF, the cerebrospinal fluid, is now patched up, no more leakage, the pressure is built back up, so the brain is held back in its position. So MR is a sort of a prognostic indicator in these babies to see whether the surgery was successful or not. And in those babies, we also look at the fiber tracts and see in these babies, the ventricles are enlarged. That's why they have some abnormalities, complications down the road. So we measure these ventricles. We also look at the tracts and see how this ventriculomegaly affects these tracts, whether the motor function is worst at birth or it begins to decline in later in the age. So we follow up these patients. The another area is called congenital diaphragmatic hernia. That is when there is a diaphragm which separates the organs below which, liver and everything below, and above that is the lungs and the heart. There is a diaphragm which separates that. And some babies, there is a hole in this diaphragm. It doesn't close. When that happens, the organs begin to move, migrate towards chest. Look at this, intestine has moved into chest. Part of the liver has moved into chest. As a result, these lungs are not fully developed because it has no room to expand because these organs have taken that place. When the lungs are not developed, that is a problem. That's why whenever the baby is born, the first thing they want to make sure whether baby cries. That means the lungs are okay. So when that happens, what surgeons do is they go through a tube to trachea of the baby and put a tiny balloon. And this is the balloon that is placed there and usually placed around 28 weeks of gestation. What happens is when you put a balloon there, there is no room for lungs to expand up north. So it begins to expand sideways, pushing these organs. We want to make, and we take the balloon out in 34 weeks. Okay, about 6-7 weeks we keep. And the placement is just about the bifurcation. Now, why do we do that? Because we want to fix this baby. As soon as it is born, we can't fix that while it is in the womb. So we want to bring the baby out. But if the baby cannot breathe on its own when it is out, it becomes very difficult. They have to put in a special device called the ECMO. When a lot of tubes are connected to make it breathe, then it becomes very difficult to perform any surgery. So what we do is we want to make sure lungs are sufficiently developed so that baby can breathe on its own, so we can do surgically perform the rest when the baby is born. Here is the image where MR helps to see. This is the trachea, this is corona, this is junction, and these are the lungs. As you can see, we can put a little camera and I can just simply walk through the trachea and see the placement of balloon in this trachea little tube. Okay, so you can see these are all off-the-shelf programs or the computer routines. These you just pull it and you run it. This is done using a program called Slicer, which is a NIH freeware program anyone can download. Then we use the Maya software to create this camera and to walk through the trachea. So today, this is where we are currently. This is the state of the art at present. MR obviously is very well established as a single most useful imaging modality today available in radiological practice, especially for the detection and characterization of soft tissue pathologies, such as solid tumors that you saw in some examples I showed you. The question is, are we there yet? In other words, is it sufficient for the patient care? Does it answer all the questions? The obvious answer is no. Why no? Because here is the picture that illustrates all. This is a talk given by Dr. Gambhir from Stanford a few years back. Here's the picture. See, late stage therapies are relatively ineffective. What do I mean by that? Today, more and more patients come to doctors when the cancer is fairly well developed, when they recognize it, there is a cancer. In other words, by then it is too late. What we call early detection is relatively late, and late stage cancer therapies are ineffective because many drugs have potential to work, but they don't work because of the cancer load or the tumor burden. If the tumor is fully developed, it becomes very aggressive. But if you detect it early enough, before it proliferates, before it becomes massive, certainly we can, kill that tumor, or, we have drugs to do that. Unfortunately, because of the patients coming at a late stage, unfortunately, that is not so. If you look at this survival rate, if patient comes around stage 1 detected, survival rate is fairly good. If you look at, when you go to the higher stage 2, stage 3, look at the survival rate. Yet, most dollars are spent in this area of research. Why? Because the problem is rather easy. We can look at the problem when the problem is developed, fully developed. MR can tell you the anatomy, structure, tumor very well when it is fully developed. But that's not good enough for patient. As you saw in that picture, it's too late. We need to change our focus from here to looking at here, which is rather challenging problem. How early is early enough? Many people, are asymptomatic. They don't show any symptom until it is fully developed. So what do we do? Here is the picture, is a patient with the breast cancer. She was detected at during stage 1. You can see this little black dot, where they sent detected that, ignore this what's on the head. That has something to do with the detection. That has nothing to do with the tumor or anything. And look at this patient here, totally different patient, detected at stage 4, when it is proliferated and metastasized the whole body. Obviously, you can detect it very well, but it is not favorable outcome for the patient. So we need to focus to be in this area. How do we do that? If you look at, this is a case, for example, Alzheimer's disease. If you look at the time scale here, now this is the threshold here. Okay. Now, this is a normal and this is mild cognitive impairment, begins to form it. Later on, it develops into what is called dementia. It's a full-grown Alzheimer's disease. Most high-risk patients, you detect the MCI, the mild cognitive impairment, early than the low-risk patients. We don't see them. Now, this green you see, this is currently what we do. Nowadays, they have different molecules. This is called molecular imaging. That's where I want to go to now. Using a different molecular agents, we can bring this curve shifted to the right, as you can see. Now, we want to bring this threshold down too. We want to be able to detect when it is in such a low concentration. By this time, whether it is a cancer or something, when it is fully developed, yes, you can detect. But can you detect when the concentration of those proliferating cells are so low? In breast cancer, for example, 1 centimeter mass, pretty much the woman can feel it. It's a very palpable, that means that 1 centimeter contains almost 3 billion cells, tumor cells. We want to reduce that size to 1 millimeter cube, not 1 centimeter cube, where the cells are about thousands, not billions, but thousands. So we need to make our instrument, number one, very sensitive to detecting that. Secondly, we need to improve the signal to noise. In these 1,000 cells compared to 3 billion cells, there is a tremendous signal difference. We need to be able to capture such a low signal as well. So the trend is now towards molecular imaging. We are very good, successful anatomic imaging. We were able to do good physiological imaging, that is the blood flow, beating heart, lungs, etc. Now we are heading into what is known as a molecular imaging. What do you mean by molecular imaging? That is, we spend a molecular spy into the body, and that molecular spy will go into your body, go around, mingle with other cells, and find out if there is any pathology, either send a signal back to you or do something that we can then observe using the available tools. For example, back in 1960s, there came a movie. I don't know if some of you may have seen it. It is called Fantastic Voyage. It's a Hollywood movie. It's a science fiction movie. And in that movie, what they do is they miniaturize humans to the size of a cell, and they inject them in the bloodstream. And here is a little snippet of that.
4 men and a beautiful girl, off on a fantastic voyage, actually entering inside the human body, exploring an unknown universe, unknown danger. Four men.
So, you see, this was a science fiction in 1966. Now it has become a reality. Although we're not sending a humans, miniaturizing them. Instead, we are sending spies, molecular spies. They will do the same thing what these humans in this movie did. They did go everywhere exploring the body, and wherever there is a problem, they sent the message back to the main center, and the center would guide them what to do, how to fix that. And that was this movie was all about. And the same idea now has become reality. We are sending the molecular spice into the body and let that molecule do one of two things. Either send a signal back, which you can learn from that and appropriately treat it, or that molecule is designed to do something to that area where it detects, and that disturbance can be then measured with available tools.
Four men and a beautiful girl.
Okay. So molecular imaging is a spy molecule travels through body observing what cells are doing, how they are functioning over time, detect any change in physiology, biochemistry, before perturbing an anatomy and relay back. So, which is very nice because you are using authentic physiologic environment to study its own cells. But the successful molecular imaging rests largely on two factors. Like I said, it has to have very high signal to noise because you ought to be able to detect extremely small quantity of tumor cells. Secondly, you better have a very high spatial resolution. It should be able to resolve it very well. No single imaging modality can fulfill that. Today, we have a PET imaging, extremely high sensitive, which can detect concentration up to 10 to the negative 11. Unfortunately, its resolution is extremely poor. On the other hand, MR imaging can play a role because our resolution is now quite improved with the sophisticated gradients and the powerful magnets. And only drawback is we may not be able to detect a concentration lower than 10 to the negative 3, whereas the PET can detect as low as 10 to the negative 11. So given that, how can you still use MRI? Here is the high resolution image back in 84, so poor quality. Look at now, you can look at red nucleus substantia nigra, so well resolved. It's a brain stem. What we use, what we call is a liposome. This is a molecule, this is a phospholipid bilayer. And what this is like a shell. It has a bilayer membrane. It has a polar head, which is in blue, and these are polar heads. And the tails are opposing each other. This is the hydrophobic part, which sort of goes against the water. It cannot retain the water. This is hydrophilic part, which is likes the water. And we use such molecules, then it has a polymer glycol on the surface. To that, we attach what is known as a ligand or ligand, ligand, which is, imagine this is like a positive and the negative is the corresponding the tumor. If you know a particular tumor and you know what are the receptors on the tumor cells, what kind of receptor it has, then you can develop appropriate ligand so that can conjugate with that receptor. That means when you let this in the bloodstream, it will go directly to that receptor. That's where it is attracted most. Once it goes there, a lot of things this can do. It can then open up and spill out all the drugs that is contained in this, or we can fill it up with the contrast agents. So we can do imaging MR imaging. And how does it break? You can use the temperature to break. Tumor has slightly higher temperature, so we can design so that as soon as it reaches there, it explodes, so giving the contents out. Or you can use the pH as a base to explode this. Tumors have a lower pH than the soft tissue around it. So you can make a switch that will make it explode based on temperature or pH, and this is packed with the drug or a contrast agent. And we use this technique in our lab. Since I was working in the fetal imaging, in fetal imaging, we look mostly the pregnant woman. And a lot of times pregnant women have other problems too. They just don't come with only pregnancy as a issue. They may have tumors in their brain. They may have spinal problems. They have liver problems, other problems, just like other people. So when you have problems like that, we have to give a contrast agent to study and characterize that pathology. Unfortunately, we cannot give this contrast agent to pregnant patient because it will circulate, go into the placenta, and from placenta into the fetus. And when it gets into the fetus, it ingests, fetus will ingest and circulate within this amniotic fluid, and it will remain there. It can become toxic eventually. So we don't give any contrast agent to the patient. So in those cases, how are we going to look at these patients without contrast? So we use this liposome GAD. And if you look at this GAD, the size is typically 150 nanometers compared to contrast agent, which is about 2 nanometers, can easily seep through membrane, whereas this cannot cross through the membrane. So we use that, and we wanted to see whether it will cross the placenta. This is the placenta, and this is the fetus. If it crosses the placenta, what is there is the umbilical cord, which connects the mother to the baby. If it gets into the placenta from placenta into the fetus, here's the picture. If it gets into fetus, we have a problem. And we wanted to prove, if I use the contrast agent packed in the liposome molecule that I showed you, it probably stays only in placenta, will not get into the fetus. And we did study that. We took this and we placed the contrast agent on the surface. We didn't put any ligand because it is now non-specific in the sense it will go everywhere where the blood goes. Obviously, blood also goes to the fetus. So this will be carried to the placenta. And we measured what happens in the placenta. Here's the mouse, pregnant mouse. You can see the placenta lights up with you see this lighting up. These are all placenta. These are all the pups here. You don't see that. Right next to placenta is all pups. There are about 7 or 8 of them. Then we measured the signal with the conventional agent. Obviously, we measured the signal in fetus increased. That means it went into the placenta. We look at the saline, just the water was injected. We did not see any. Obviously, we shouldn't see any. Compare that to with the liposome. It remained the same as what we see here. That means in fetus, when you inject the liposomal contrast, did not go into fetus at all. When we sacrificed this and measured actual concentration, you can see in the conventional agent, it increased. It was high. This was a threshold level for detection. It's above the threshold level of detection. In placenta was obviously very high. Fetus also very high. But if you look at the liposome injected study, it was below the threshold in fetus, although it is high in placenta. We don't care if it goes into placenta as long as it doesn't go into fetus. This was very useful because in the future, if this drug is approved, we can use this as a contrast agent to study pregnant patients with any pathology. So nowadays they have designer molecules, liposome. You can put appropriate ligand here. That ligand that goes into, this is the cell, and cell has a receptor, and it will just attach to the receptor. It will go right where it is needed. As long as you know what is the receptor of this cell. So from the studies, pathology studies, etc., we can determine what are the receptors for a particular cancer cell. That way we have found out receptor for liver cells, kidney cells, heart cells, tumor cells, all these things. And then we can just determine appropriate ligand you attach to this liposome. And this is the now carrier. This can be packed with the appropriate cancer drug. Then what happens? It will only deliver the drug right where it is needed. Currently, we are giving the chemotherapeutic agent through the bloodstream. It can destroy many of the healthy areas. That's why when the chemo is taken, patient loses hair, becomes weak, anemic, all kinds of other problems come because the drug has gone elsewhere in addition to the where it is tumor cells. It will kill tumor cells. At the same time, it may kill normal cells as well. This way, you can design the drug. It goes directly to the cancer area and distribute the drug. And what we are doing in MR is, instead of a drug, we fill this with the contrast agent, and then we image once it explodes with the contrast at the cancer. These receptors, various types of receptors are there, which is all well studied. And we determine that and find the proper ligand. And the ligand can be, the agent can be extracellular or intracellular. Intracellular means the drug can go inside the cell. Extracellular means it only remains outside the cell. Intracellular is very nice to achieve because there are a lot of targets that you can work with within the cell. But it's a very difficult problem because it has to cross through that hydrophobic part of the bilayer membrane. It becomes very difficult. So most of them are extracellular. Outside the cell, it sort of explodes and gives the therapeutic agent. And this is one example of Alzheimer's disease. These are the plaques that are formed, which could not be seen in a conventional imaging with the proper agents, which binds, the ligand binds to these agents. We can see this nice. In the Alzheimer patient, there is a toxicity in the brain. Normally, in the normal brain washes that out, but when this toxic material is built up, then it collects, aggregates together and forms a plaque. And this is what we see. When the plaques get increased, then you have problem of memory, dementia. It affects all parts of the brain. Here are the amyloid PET ligands that are made. And here you can see a negative scan, a normal brain versus a positive Alzheimer patient's brain, where this has attached to this area and lights up. And in our lab in Texas Children, they are studying various ligands for the appropriate cancer therapies. So here is an example of that in mouse brain. After giving that, it goes to where those plaques are built up. So in conclusion, so molecular MRI obviously rely on synergy of these sophisticated techniques that we can exploit, and the development of novel contrast agents. We can take advantage of our current knowledge of molecular process and disease. The thing is, currently it takes about over the few years back, it used to take 6 years. Now it takes only 2 years from a laboratory bench experiments to human studies. So this is what I wanted to share with you. Thank you very much for your attention. I'll be happy to answer any questions.